Most people still believe something dangerous. If a surgeon recommends an operation, it must be the right choice. The specialist knows best. The scan is already done. The hospital has the equipment. The consent form is printed. Just sign here. I used to watch that moment happen all the time. A patient sits in a chair, frightened, overloaded, trying to look brave while a family member nods along because everyone in the room wants the same thing. Fix the problem. Remove the danger. Move forward. And on the surface, that sounds reasonable, until you start counting. Counting the patients who went into the hospital hoping for relief and came out permanently changed. Not always better. Changed. A man who walked into surgery with back pain and walked out weaker, more unstable, and afraid of stairs. A woman who technically survived open heart surgery but lost months of her life to confusion, infections, and exhaustion no one had prepared her family for. A retired engineer who was told surgery was his best option by 3 different specialists, only to discover that the real threat was not the condition alone. It was what the operation might take from him. I'm Dr. Adrian, and today I'm going to tell you the truth about 5 surgeries that carry serious hidden risks for people over 60. Not because surgery is bad, it isn't. Not because surgeons are careless, most are not. And not because older adults should live in fear of hospitals. They shouldn't. I'm telling you this because far too many people are warned about the disease and almost never warned honestly enough about the recovery. And in older bodies, recovery is where everything changes. That is the sentence I want you to remember. In older bodies, recovery is where everything changes. Because here is what most people do not understand. The older your body is, the harder it has to fight just to survive the operation itself. Not the disease, not the diagnosis. The operation, the anesthesia, the blood loss, the stress response, the bed rest, the pain medications, the inflammation, the strain on the heart, the lungs, the kidneys, the brain. You can remove a tumor and still lose the patient to complications. You can fix a blocked artery and still watch someone disappear into weeks of delirium and weakness. You can technically perform a successful operation and still destroy the life the patient was trying to protect. That is the hidden part. And that is why I need you to stay with me until the end, because the most important thing I'm going to give you today is not a list of risky surgeries. It's a way to think, a way to ask better questions, a way to avoid being rushed into a major decision simply because someone in a white coat sounds confident. Let me ask you something. If you take a brand new car and a car with 200,000 miles on it and put them through the same stress test, do you expect the same result? Of course not. And yet medicine spent a very long time pretending that a 72-year-old body could be pushed through the same kind of surgery with the same assumptions and the same recovery expectations as a 42-year-old body. Same protocols, same timelines, same cheerful promises about being back to normal soon. That is changing. But not fast enough. Because here is what actually happens inside an older body under major surgery. The heart works harder to remain stable under anesthesia. The lungs clear anesthetic drugs more slowly and are more likely to struggle after the operation. The kidneys process medications less efficiently, which increases the risk of injury, confusion, and longer recovery. And the brain, this is the one that catches families off guard, can become temporarily disoriented in ways that last not hours, but days, weeks, and in some cases, months. Doctors have names for these things: postoperative delirium, cognitive dysfunction, functional decline, failure to rescue, frailty-related complications. But families don't experience those as terms. They experience them as this: he survived, but he's not himself. She was fine before surgery, and now she's confused all the time. We thought the operation was the hard part. No one told us the recovery would be worse. Now let me be absolutely clear because I do not want this misunderstood. Age alone is not a reason to avoid surgery. I have seen 82-year-olds recover better than 58-year-olds. Age is not the whole story. Reserve is the story. Frailty is the story. How much stress the body can absorb before it starts to break down, that is the story. Frailty is not a moral weakness. It is not laziness. It is not giving up. It is a medical state in which the body's reserve has dropped low enough that even a routine stress can trigger a disproportionate collapse. And that leads us to the question that matters far more than most patients realize. Not, can I survive the operation? But, can I survive the recovery and still have a life that feels worth saving? Those are 2 very different questions, and if no one has asked you the second one, then no one has had the full conversation with you yet. So let's start with surgery number 1, open heart surgery in frail patients. Now I want to handle this carefully because open heart surgery has saved countless lives, and I will never pretend otherwise. Coronary artery bypass grafting, valve replacement, complex cardiac repair. For the right patient, these operations can be absolutely transformative. A blocked artery is bypassed. Blood flow improves. Chest pain decreases, survival improves. But when people hear open heart surgery, Many of them picture a single problem being fixed. That is not what it is. Open heart surgery is not just a heart operation. It is a full-body stress event. The chest is opened, the circulation is manipulated, powerful drugs are used. In many cases, the patient is placed on a heart-lung machine, meaning a machine temporarily does the work of both the heart and the lungs while the body is exposed to one of the most demanding physiological insults modern medicine can create. A healthy 60-year-old with good kidneys, decent lung function, strong muscle mass, and no cognitive impairment may tolerate that remarkably well. A frail 78-year-old with diabetes, chronic kidney disease, memory decline, poor stamina, and weight loss is not facing the same operation in any meaningful sense. On paper, it is the same surgery. Biologically, it is not the same event. And this is where families get blindsided. They hear that the artery is blocked. They hear that the surgery can fix it. They hear the surgeon say, "We do this every day." What they do not hear clearly enough is what the whole body has to endure to survive it. Stroke, kidney failure, prolonged time on a ventilator, severe confusion, new irregular heart rhythms, infection, months of weakness, loss of independence. I remember an older man, late 70s, proud, disciplined, the kind of patient who wanted the most definitive solution available. He told me, "I don't want half measures, doctor. If it needs fixing, fix it." I respected that instinct. But when I looked at his whole picture, not just his arteries, the story changed. His kidney function was slipping. His walking tolerance was poor. His wife quietly told me he had been forgetting things. He had the mindset of a fighter, but not the reserve of one. And that is where medicine has to grow up. Because courage is not enough. Willpower is not enough. A strong personality cannot compensate for a body that no longer has the reserve to absorb a major physiologic assault. For a patient like that, the question is not simply whether the surgeon can perform the operation well. The question is whether the operation is too much for the body to pay for. And in many cases today, there is another path worth discussing. Transcatheter procedures, less invasive valve interventions, selected stenting strategies, medical optimization. Does that mean open heart surgery should be rejected automatically? Absolutely not. But it does mean every older patient should ask this question and ask it directly. Am I a candidate for a less invasive approach? And if not, why not? That one sentence can completely change the trajectory of care. Now let's move to surgery number 2, aggressive spinal surgery for chronic back pain. This one frustrates me deeply because it sits right at the intersection of pain, hope, and overselling. Back pain is almost universal after a certain age. I don't know many people over 70 who haven't had some version of the same complaint. Low back pain, sciatica, stiffness, pain standing, pain walking, pain that sits in the background of life long enough that it starts to feel like identity. And because the pain is real, and because people get tired of suffering, surgery starts to look like rescue, fusion, hardware, multi-level decompression, screws, rods, the promise of finally fixing what has been hurting for years. Now I need to be very careful here. Some spinal surgeries are absolutely necessary. A severely compressed spinal cord, progressive weakness, loss of bladder or bowel control, rapidly worsening neurologic symptoms, those are very real surgical situations and can be urgent. But elective, aggressive spinal fusion for chronic degenerative back pain in an elderly patient is a much more complicated story than people are often told. The older spine is not simply broken. It is adapted. It has shifted over decades. It has compensated unevenly. Some segments are stiff, some are overloaded, some are degenerating, some are inflamed. When surgery locks down one area, the rest of the system often has to absorb the cost. Pain may change rather than disappear. Mobility may improve less than hoped. Recovery may be long, painful, and incomplete. And adjacent levels of the spine, the vertebrae above and below the fusion, may begin to break down faster because the mechanics have changed permanently. I remember speaking with a man in his early 70s who had been told surgery was basically the next logical step. He wasn't paralyzed. He wasn't losing bowel control. He was simply tired of pain and desperate for a conclusion. That desperation makes people vulnerable. He went through a major fusion and later said something I wish more patients understood before they signed consent forms. No one told me the best-case scenario might still be disappointing. That sentence says everything. Because when people hear surgery, they often imagine resolution. But in chronic degenerative spine disease, especially in older adults, surgery may offer partial improvement, different pain, a long rehab course, and a body that never quite feels like the one they hope to get back. Does that mean never have spine surgery? No. It means ask much better questions. What exactly is this surgery trying to fix? Is the goal pain relief, nerve protection, walking improvement, or better imaging? What is the evidence that this surgery gives better long-term function than physical therapy, guided exercise, injections, medication adjustment, balance work, and time? And one more question that matters enormously. If this surgery goes perfectly, what level of improvement is realistic for someone my age and condition? Not idealized improvement, not brochure improvement, realistic improvement. If the answer is vague, if the benefit is being sold harder than it is being defined, that is information. Now, surgery number 3. Major cancer resections in frail older adults. This is the most emotionally charged one on the list, because cancer changes the emotional temperature of every conversation. The minute most people hear that word, one instinct rises above all others. Cut it out, take it out, do something, and I understand that completely. But surgery should never be judged only by whether a tumor can be removed. It has to be judged by whether the whole patient benefits. That means asking whether the treatment will deliver more good life, not just more intervention. Major cancer surgery can be extraordinarily hard on the body. Pancreatic surgery, esophageal surgery, large liver resections, complex colon operations. These are not small events. They can last many hours. Blood loss can be substantial. Nutrition afterward can be difficult. Intensive care may be required. Complications can pile up quickly. The body may survive the operating room and then begin to fail during the recovery it was not strong enough to endure. I remember a family meeting with an older man who had a resectable tumor. On paper, surgery was an option. In a younger, stronger patient, it might have been the obvious recommendation. But this man was frail. He had heart disease. His kidneys were weak. He had lost weight. He was already having trouble bouncing back from ordinary illness. And yet the family's first question was exactly what you would expect. If it can be removed, why wouldn't we remove it? Because removing tissue is not the same thing as preserving a life. That is the answer. Sometimes surgery gives someone more years. Sometimes it gives someone more suffering. Sometimes the technically correct operation produces the humanly wrong outcome. That is not easy to say, but it is true. This is why older adults with cancer and their families need to ask a question that is far too often skipped in the rush to treatment. If we do not operate, what does the non-surgical path realistically look like for someone my age, my frailty level, and my overall health? Not in theory, not in a younger person, in me. That question can open doors to radiation, targeted therapy, immunotherapy, symptom-focused treatment, or carefully chosen supportive care approaches that may preserve far more meaningful life than a heroic operation the body cannot truly survive. And let me be clear, this is not surrender, it is strategy. Now surgery number 4, elective joint replacement in severely ill patients. Hip and knee replacements are among the great success stories of modern surgery. For the right patient, they are life-changing. I have seen people go from living in pain, barely walking, to moving freely, sleeping better, regaining independence, and getting parts of life back that pain had taken from them. So this is not a warning against joint replacement itself. It is a warning against ignoring timing, preparation, and physiology. The word elective matters. Elective means the operation is planned. You are not bleeding to death. You are not in a midnight emergency. You have time. And when you have time, you have responsibility. Responsibility to ask whether your body is actually ready, because a 76-year-old with well-controlled conditions, decent muscle mass, good mobility, and solid support at home is not the same patient as a 76-year-old with uncontrolled diabetes, obesity, severe heart disease, poor circulation, kidney issues, and almost no ability to exercise. Again, same surgery on paper, different surgery in real life. What worries me is how casually people sometimes talk about joint replacement, as if common means minor. It does not. Blood clots can form, pulmonary embolism can happen, pneumonia can develop from prolonged immobility, wounds can heal slowly, heart strain can derail recovery, and the biggest hidden loss can be this. The patient never regains the function they imagined because the body was not prepared enough to benefit. I think of a woman in her late 70s who wanted a knee replacement badly and understandably. Every step hurt. She was miserable, but her blood sugar was poorly controlled, her blood pressure was unstable, and she became winded walking only short distances. She saw surgery as rescue. But rescue without preparation can become injury. What she needed first was not an operating room. She needed prehabilitation, better blood pressure control, better glucose control, nutrition support, strength work, breathing work, walking tolerance. A stronger foundation so the operation had something solid to land on. That is what older adults need to hear more often, not just, you need the surgery, but, here is how we get your body ready to survive it well. So if joint replacement has been recommended to you, ask this. Is my body in the best condition it can realistically be in before this surgery, and what can we improve first? If no one has discussed that with you, then the conversation is incomplete. Now surgery number 5. Emergency abdominal surgery. This one is different because you often do not choose it. It chooses you. A perforated bowel. A ruptured appendix. A bowel obstruction. Internal bleeding. Severe infection in the abdomen. These situations do not wait for a leisurely office conversation. They erupt. They force decisions. They terrify families. And in older adults, especially over 75, they carry some of the highest mortality risks in all of surgery. Not because surgeons are incompetent, because an elderly body under sudden trauma is fighting on too many fronts at once. The infection or rupture is already damaging circulation. The inflammatory response is already surging. Blood pressure is unstable. Organs are under stress. Then anesthesia is layered on top. Then the surgery. Then immobility. Then pain medication. Then the risk of delirium, kidney injury, lung failure, sepsis, or multiple organ decline. A younger body may absorb that cascade. A frail older body may not. That is why emergency abdominal surgery belongs on this list. Not because you can always avoid it, but because understanding the risk before the crisis changes how you prepare for life. It means you stop ignoring abdominal symptoms. Persistent pain matters. Significant bloating matters. Changes in bowel habits matter. Vomiting matters. New severe constipation with pain matters. The best way to survive some emergencies is to treat the warning signs before they become emergencies. And there is another reason this matters. Families need to talk before the midnight hallway conversation ever happens. What are your wishes if emergency surgery becomes the only option? What kind of quality of life matters most to you? What trade-offs are acceptable, and which are not? Those are not morbid discussions. They are loving ones. They spare families from having to guess in panic. Now we've covered the 5 surgeries, but the real power of this conversation is what you do next, because information without action becomes anxiety, and I do not want to leave you anxious. I want to leave you armed. Before any major surgery, planned or recommended, there are 4 questions every patient over 60 should ask. The first question is this: what happens if I do not have this surgery right now? That question is incredibly powerful, because if the answer is that nothing urgent changes for 6 months or even a year, then you have time. Time to think. Time to get another opinion. Time to improve your health. Time to ask harder questions. Time to choose rather than react. The second question: is there a less invasive alternative? Medicine has changed dramatically in the last 15 years. Catheter-based procedures, robotic approaches, laparoscopy, endoscopic interventions, image-guided treatments, options exist now that did not exist before, or were not offered as often. You may not qualify, but you should absolutely ask. The third question: what does recovery realistically look like for someone my age, my frailty level, and my health profile? Not the average patient, not your youngest patient. Me. What are the odds I return to my current level of function? How often do patients my age need rehab? How likely is confusion? How likely is loss of independence? How long before I am walking well? How long before I am myself again, if I ever am? And the fourth question, the one most patients never ask: what is your personal complication rate for this procedure in patients over 70? A good surgeon tracks outcomes. A confident surgeon can discuss risk honestly. If the room gets uncomfortable when you ask that, pay attention. That discomfort may be more informative than the answer itself. Now, before I close, I want to leave you with something hopeful. This is not a message about avoiding medicine. It is not a message about fear. It is a message about options. Minimally invasive surgery has transformed what is possible for older adults. Catheter-based heart procedures now help patients who once could never have tolerated open surgery. Laparoscopic operations reduce recovery burden dramatically in selected cases. Robotic techniques can improve precision. Good medical management, physical therapy, targeted injections, pain management, nutritional support, and frailty optimization can sometimes achieve what people assume only a knife can achieve. In other words, surgery is no longer the only serious tool in the toolbox. That matters. And I want to tell you about a patient I'll call Gerald. Gerald was 71, a retired engineer, thoughtful, sharp, not easily intimidated. 3 surgeons had recommended open heart surgery. 3 opinions, same conclusion. Most people would have stopped there. Gerald didn't. Not because he distrusted doctors, because he had watched his wife go through a major operation and survive it physically, while losing herself for months afterward. He told me something I have never forgotten. She went in as my wife and came out as someone I had to take care of. That is one of the most honest sentences I have ever heard a patient say. So Gerald asked the question too many people never ask. Not just, can surgery fix the problem? But, what will surgery cost me, given my body, my kidneys, my cognitive baseline, my actual reserve? We reviewed everything, slowly, thoroughly, honestly, and what became clear was this: surgery was one option. It was not the only option. For his particular profile, aggressive medical therapy combined with rehabilitation offered a very reasonable alternative. He chose that path. Years later, he was still living his life, still walking, still thinking clearly, still being himself. Would surgery have been automatically wrong? No. Was it the only answer? Absolutely not. And that is the most important thing I can say to you today. A surgical recommendation is not a verdict, it is the beginning of a conversation. You are not a passive recipient of medical decisions. You are an active participant in your own care. You have the right to ask hard questions. You have the right to request alternatives. You have the right to get a second opinion. And if necessary, a third. You have the right to ask not only what surgery might fix, but what surgery might take. So let's bring this all together. Open heart surgery in frail patients, where less invasive alternatives may preserve more of the person, not just the organ. Aggressive spinal fusion, where long-term benefit may be weaker and the cost much higher than patients are led to believe. Major cancer resections, where the goal must always be more good life, not just more treatment. Elective joint replacement in severely ill patients, where preparation can matter as much as the procedure itself. And emergency abdominal surgery, where early symptom awareness and early family conversations may make all the difference. This does not mean avoid surgery. It means stop thinking of surgery as a default answer just because it is the most dramatic one. Your age is not a weakness, but it is a reason to ask better questions. Not weaker questions, better ones. If you remember nothing else from me today, remember this. The surgeon may hold the scalpel, but you hold the choice. And an informed choice, made clearly, calmly, and with full respect for the reality of your body, is one of the most powerful tools in medicine.